If you're interested in a one-on-one conversation with me, where we can look over your data or discuss anything sleep, I've left a link in the description.
So it looks more like a belt or a band. That's where you want to look like. There's always going to be a little fuzziness, but you really want it to be like a nice belt or a band. Can you see it, Oscar?
Yeah.
All right. So this is a person who has high loop gain apnea, and this is actually a positional problem. High loop gain apnea is more when a person is on their back than on the side. And this person on their back, we really can't fix the guy. He tries really hard to sleep on his side, and we told him, should really take heroic measures to try to avoid being supine. But this shows the pattern of what happens when you have expressed high loop gain. Now, even here it's a little bit fuzzy, but tolerable. I mean, this is fine. I mean, I could live with this. Now it starts getting a little wobbly, and boom, totally gets out of hand. So this person was fine on their side. On their back, they have great instability. The system is barely picking up these things. His overall AHI, as estimated by the system, is 8.23 in front of my face. This is not 8.23. This is mayhem going on. It simply just doesn't, again, it's rule-based. It doesn't fit a given rule. It's too short, too long, too whatever. It simply doesn't pick it up. But let's actually see how bad this is. This is terrible. The ATS recommendation is, as long as it's under 10, machine estimated, everything is fine. That's rubbish. Look at this. This is crazy. Oh, finally, some decent breathing. Bad. Super bad. This is not good at all. We can look at another night. Look at that. 10. Threshold. What threshold? This is almost as good as, this may be worse than no treatment, because this must be pretty bad, right? I mean, look at that. And it's picked up this one. It missed. Okay, picked up. So this large one is picking up, which is reasonable. Thank God. It's not picking up any of these. So it has its rules. You either fit into that or it doesn't. But when you look at it, this is a better night. At a glance, a fraction of a second, this is not good, right? You don't need to, anyone can be taught to recognize this as being not good. And this one as being clearly better. Even then, there's some instabilities. So you can, there's some instabilities, but it's clearly not as bad as the other one. And one of the reasons why people have these fluctuating nights, when they have a really bad night, they have so much sleep drive left behind, the next night they sleep better. So they oscillate, basically. Good nights, bad nights, body position, of course, makes a difference. Even though this is better than some of the other ones, each time it looks like a brush. So I tell my patients, when it looks like a band, that's good. When it looks like a brush, doesn't look good. And those who play with guns, the gun brush, how you clean? If it looks like a gun brush, not good. It means that there are irregularities. When you compress it, it'll look like this. So each time there is this abrupt change in ventilation, it's an arousal. It turns out when we are sleeping, whenever there is a brief arousal, there is always increase in tidal volume. You always take larger breaths. Each time you have that, you're also going to. So one thing I do when patients come to clinic, I run it like a movie, sort of, You can stop and, peer into a worse than average night. And the more night to night variation there is, like some nights are like really bad, usually the more symptomatic the person is.
The more variation, the more symptomatic.
Yeah, usually.
So in one of these less, let's say, disruptive nights, what's the treatment of choice for this specific patient? What should they
Oh, so this person, in his case, this person is already on dead space, CPAP, acetazolamide. You know, it's really it's body position. That's the only thing which we have left. We are given everything else which we can, but and this one we know when he's in the lab, he's had retitrations and whatnot. When he's on his back, nothing works.
do we
We
know why
could
that is?
add, sorry?
Do we know why that is? Like, what is the difference? Like, why is it causing such a significant
All right.
difference?
So I call these people supine monsters, affectionately. There's a subset of patients, and it's almost always patients with high loop gain who are impossible to fix when they're on their back. And I think there are many reasons. First of all, loop gain is a bit more on their back. The gravity effect pulls the jaw back a bit, so there's an added obstruction to it. And certainly, if people use a full face mask, you can push the jaw back. Something to watch out for. And then I think epiglottic collapse. The epiglottis, normally protects the airway when we swallow and so on. It can fall into the airway when we are, you know. And patients who have this pattern, I recommend a drug-induced sedation endoscopy, DICE, which is normally used, before hypoglossal stimulation, as an example. I sort of recommend to them. Some will do, some will not. But those who have done, it's a pretty good hit rate of epiglottic collapse. About half of them have epiglottic collapse. Variable amounts of, not complete, usually partial. So I think a combination of a floppy epiglottis plus gravity effects plus loop gain effects, it's a perfect storm type of thing. And we can't quite get over it. Could there be some change in cerebral blood flow? Based on body position, that's plausible. But these three are probably enough to explain why. And it's amazing how impossible to fix they are. Every now and then there will be a person where we add an oral appliance, and even when they're on their back, they are better, suggesting that if we can really stabilize the airway, you can do well. Otherwise, when a person sleeps on the back, the jaw always falls back some. Anybody, everybody. And maybe these folks, the jaw falls back a bit more than average, so it adds an obstructive element to whatever else is going on. A person can have a similar pattern in REM sleep, but it won't be periodic breathing. It'll be more pure obstructives, where the tone of the jaw, these muscles go, the jaw just falls back into the throat in REM sleep, or the jaw opens, the whole lower phase becomes totally floppy in REM sleep. But that's a REM sleep specific issue. But these supine monsters are really non-REM monsters. So he is a supine monster.
So am I understanding correctly that this patient has been improved to the as much as possible, and that there's just some degree of disordered breathing that's lingering that he's not going to be able to get rid of?
At this point, that's more or less it. Now, does everybody sleep like a band or a belt all night long? No. Is this amount of instability problematic? It could be, biologically speaking. So what we need to know is whether, as an example, at night, blood pressure drops, blood pressure dipping. Those who have unstable breathing on treatment, are they more likely to have blood pressure dipping or not? Non-dipping or not? That's an important question to ask. But it's very, very few people who look at this level of data. I will guarantee you that patients are looking at Oscar more than physicians.
Do you still hold the position that, what percentage of patients do you believe just aren't going to, even after trying everything. I'm a hopeful guy. I still think that we can cure everyone at some point in time in the foreseeable future, I hope, through drawing, let's say, relationships between data that we weren't able to draw before. And just as people begin to focus more and more on sleep medicine, I think it's, been under the radar more and it's kind of going a bit more mainstream. At least that's my perception. But what percentage of patients do you find, or maybe the patients you get are kind of biased because people come to you who can't find solutions, right? But what percentage of them do you find can't fully resolve their sleep disorder breathing?
In my population, I can get to about 70%.
70%.
About 70% of my patients, this is my own data. This is our data. This is not just me making a number up. This is our data. About 70% we can fix breathing, sleep decently. Sleep still is a bit fragile. These patients are not as, their night is not as smooth as straightforward OSA. But 70% we can fix well. Takes a lot of work, and the patient does have to, there's no room for error, so they have to be really careful about everything. Nasal patency, weight, of course, body position, if they are supine monsters, and they have to use adjunctive therapy like acetazolamide and so on. So 70, yeah. But there is still a substantial need in patients who don't do well. Now, I see mostly these days patients who have failed treatment already, and we are still sticking to that 70%. So that's pretty good. Not great that 30% we still are out of ideas, and then we end up doing oral appliance plus oxygen, Inspire plus oxygen plus acetazolamide. So we don't give up. I mean, as long as the patient is willing to work with us, we will find something which will medications, depending on what the physiology is. There are some patients whose sleep is extremely fragile. Their breathing is not great, but they have so much awakenings. I mean, it's comorbid insomnia with apnea. The apnea can be quite substantial, but not necessarily life-threatening and so on. We may have to use a sedative. Because normally we don't use sedatives in apnea. Clearly, someone who has REM-dominant apnea, we don't use sedatives. But in non-REM dominant apnea, and I will tell you across the board that is more than 95% of patients who are really struggling is because they have non-REM dominant apnea. That's most of sleep anyway. That's 80% of sleep. It's rare to find a person with severe REM dominant apnea who is not able to benefit from PAP. They may still not use it, excuse me, for various reasons, or unable to use it at home. Every now and then we'll find someone like that. But it's usually people with substantial residual apnea in non-REM sleep who are persistently symptomatic. And that makes up most of sleep anyway.
What does your intuition say? I know we don't have an answer. I mean, that's the whole point of what you just said, but what do you think is being missed? Do you think that there's damage to the control systems, or there's damage to the arousal systems, or there's just sensitivities, or it's
both.
Yeah.
Yeah. Maybe over time they heal a bit. They probably need some help along the way. Sedative. Acetazolamide it's just one pathway which is being targeted. The carotid body is extremely complex, and oxygen sensing is really quite complicated. There's ATP, there's potassium modulation, there is gases, nitric oxide, carbon monoxide, hydrogen sulfide. I mean, for a little fella, it is really very, very complicated. For the sake of not just apnea, but also heart failure, metabolic dysfunction, hypertension, being able to modulate the carotid body function, I think will give us an additional hand. What we're doing now is to try to buffer its anger. It's still an angry little fella out there. Now, oxygen can shut off the carotid body, but the dose you need will kill you. Like the usual tolerable 2 to 4 liters a minute is not enough to shut it out. Although a subset of patients will get decent benefit from oxygen, but alone it doesn't do great.
Who
It
are
can
the
help a bit.
who are
It
the
doesn't do great.
who does well with oxygen?
It's a subset of patients who have high loop gain who are uniquely responsive. No, within high loop gain patients, there's a subset who seem to be uniquely responsive to oxygen.
I see.
And maybe between 5 and 10% at most. And I also use oxygen for patients who are older, sicker, just too much going on, heart disease, lung disease, brain disease, PAP, too much. And they get decent benefit from using oxygen at night. Often they got to pay for it themselves because Medicare doesn't care, right? So Medicare's, once you have a OSA label, it sticks to you like a leech. And Medicare has very strict criteria how you can get oxygen if you have a diagnosis of OSA. But you can get a rental for $75 a month, or you can buy a concentrator for less than $1,000. It's a bit of a charge, but it lasts for a long time. So we get a patient a trial. We ask them to use it for 4 weeks and see how it is. If they feel really much better with it, they will keep using it. So my worst of the worst are on oxygen, acetazolamide, dead space, PAP sometimes. And the PAP could be CPAP, ASV, never bilevel, can be CPAP, BiPAP ST, or ASV. Regular bilevel will make central stuff worse. I mean, regular bilevel just causes overventilation. BiPAP ST, you got to be careful. It can overventilate. But for a long time, the only thing we had was BiPAP ST. And we'll do a session on treatment options. But BiPAP ST can be used gently, not trying to overdrive the system, but gently to sort of dance with the person gently. At the same time, use body positioning and a bit of oxygen with our diamox, and we can get it to a decent place. That's what we were doing until about 2003-4 when I started using dead space. So yeah, the ASV devices are actually pretty good for a subset. I would say about 20% get a real benefit from the adaptive ventilators, unique benefit. But most of the time, I don't need to go to the adaptive ventilators. I can get the patients pretty well with CPAP and adjunctive therapy. Not CPAP alone. CPAP alone virtually never works for patients with overt high loop gain apnea, especially overt obstructive high loop gain apnea. It's not going to work. They may be able to tolerate it. They may, become adherent and declare a success. But when you look at the data, it looks like this, or worse than this. And the machine AHI will be 3, 4, 5, 6, 7. It doesn't tell you. Like on this night, it says 4.6. Yay, clap. No, of course not. It's fuzzy all night long. There's more fuzzier, less fuzzier, but it's still fuzzy. But I think patients, they should use Oscar. And, as they look at it and sort of correlate their own symptoms, they'll really try to understand it. I mean, if a patient can use home glucose monitoring to shoot themselves insulin, this is trivial compared to that.
That's true.
Right?
Yeah. Well, look, I have a million more questions, but I think we're running up against your schedule here, so they'll have to be saved for another time. But I want to thank you for your time once again. I think you're literally going to save people's lives. I know that sounds a little bit hyperbolic, but you'd be surprised. I mean, you probably know you get the patients as well. So there's a lot of people out there that are looking for answers, and this is going to give some of them some more answers.
I mean, there really are a whole bunch of people who have failed PAP for treatable reasons. Now, there are some people who have failed PAP because they have claustrophobia. So that's much harder. But high loop gain, fragmented sleep, these kinds of things are actually fixable. and most of them don't know there is a potential fix.